everybody to our keynote for our spring 2021 residency. My name is Dr. Lori Ann Stretch. I'm the coordinator for the online counseling program, and I would like to welcome Dr. Elizabeth Burgin, one of my esteemed colleagues, who will be speaking to us today about her research and work that she's doing. And so, Dr. Burgin, I will turn it over to you. I will be here, and Dr. SGS will be here to monitor chat and questions. Would you like us to hold questions to the end or share questions at certain times?
I've left some space at the end for questions.
We will hold on to those and organize them for you then. So thank you so much for being here.
Yeah, hi everyone, and thank you all for being here. I'm Dr. Elizabeth Burgin. I'm an assistant professor in the School Psychology and Counselor Education Department at William & Mary. And tonight I'm going to talk to you about adversity in childhood and the ways that we can support children through prevention and intervention. So I'm a counselor and I've worked across the lifespan. A significant component of my professional identity is that I'm a play therapist and have worked with children and families in a lot of different settings. So that's been community agency, schools, private practice, foster and adoptive systems of care, criminal justice systems, and safe houses and shelters. So for the past several years, I've been involved in research related to understanding what barriers to access children and families experience when they're seeking mental health services, and then the effectiveness of the therapies that are available to children, their caregivers, and some of the other important stakeholders in their lives like teachers and school counselors. So my intention in speaking with all of you tonight is really to try to summarize what I've learned about children who face adversity and the outsized impact that adversity can have on developing brains and bodies in children. And then what we, as people who collectively care for the well-being of our communities, can do to try to reduce the impact of trauma. So I'm going to start by operationalizing what I mean by adversity. Adverse childhood experiences represent childhood exposures to traumatic events that are cumulatively implicated in the development of chronic physical and mental health outcomes. So the original ACEs study was actually conducted by physicians, not mental health practitioners, and was published in 1998. The researchers in that study identified ACEs as comprised of experiences of abuse, which include psychological, physical, and sexual abuse, and household dysfunction, which includes exposure to substance misuse, mental illness, the violent treatment of a maternal figure, and then criminal behavior in the household. The study was conducted through a Kaiser Permanente insurance program, specifically out of the branch in San Diego, California, and more than 17,000 participants answered a retrospective questionnaire about their history of exposure to adverse experiences, and then they provided information about their medical records. So it was a huge sample. About 64% of the people in the study reported that they had a history of at least one adverse childhood experience. 54% reported that they had multiple ACEs, and 12% of the people in the study identified that they had 4 or more ACEs. And 4 is a significant number because it's correlated with significant mental and physical health outcomes across the lifespan. More contemporary research estimates that actually about 20% of youth in the United States endorse a history of 4 or more ACEs. So this landmark study provided researchers with really invaluable information about the effects of early adversity, but it had some limitations. 80% of the sample in the study identified as Caucasian and 75% identified as college educated, meaning that the researchers didn't have a complete picture of the prevalence of ACEs or their impact on communities, particularly among people who identified differently. So especially people who are minoritized. So Felidi's study was really important because it demonstrated that even among socially valued and privileged groups, 64% of the US population faced adversity. I want to highlight 2 studies that contributed to the expansion of the original ACEs study through the inclusion of community-level stressors alongside the original constructs of abuse and household dysfunction that were identified by Felidi. So community-level adversity includes acts of racism, discrimination, and violence within a child's community or neighborhood. Researchers have added community-level stressors to studies on ACEs in an attempt to better capture adversities that are experienced by the broader population and have included racial and ethnic prejudice, neighborhood violence, bullying, foster care, adoption, and exposure to natural disasters. So 20 years after Felitti and Anda's original study, a subsequent team of researchers investigated the prevalence of ACEs across demographic variables and found that participants in several socioeconomic categories reported a significantly higher degree of exposure to ACEs compared to their white, high school educated, and higher income bracket counterparts. So in particular, participants who identified as Black, Hispanic, multiracial, gay, lesbian, bisexual, with less than a high school education, who earned less than $15,000 annually, or who were unemployed, were more likely to report ACEs. So ACEs are a prevalent concern in the US population across diverse groups. And it appears that while no social group is untouched by the impact of ACEs, groups who are minoritized may be at a higher risk for exposure, particularly to community level adversity. So consistent with the findings shown on this slide, researchers Thurston and colleagues found that ACEs exposure occurred at higher rates among ethnic and minoritized groups, and that community level stressors were represented at a higher rate among non-white individuals. So specifically, they reported that more than twice as many Black non-Hispanic children witnessed violence compared to their white non-Hispanic counterparts. They also found that there's a negative relationship between the number of ACEs reported for each child and their emotion regulation capacity, and that among all of the community level variables that they tested, experiencing racial or ethnic prejudice demonstrated the strongest effect on emotion regulation among children. So another notable consideration about the prevalence of ACEs exposure is regarding children in rural versus urban areas. Crouch and colleagues conducted a national study across 35 states to explore the prevalence of ACEs, and they concluded that children in rural areas had a higher reported number of ACEs proportionally compared to children in urban areas, and specifically that children in rural areas had more reported ACEs exposure in almost all types or categories of ACEs. Blodgett and Lanigan found that children reported significantly more ACEs in Title I elementary schools compared to non-Title I schools. So these two studies, Crouch and Blodgett and Lanigan, indicate that poverty and access to services can actually mediate or explain the how and why relationship of exposure to ACEs. So here, we're going to look at the outcomes associated with ACEs exposure. You can see that the increased risk of disease is massive. The relationship between ACEs and health risk behaviors, chronic illness, and disease related to the leading causes of mortality among adults was initially established by Felitti and colleagues, but it's been confirmed in subsequent studies. So Brown and colleagues found that individuals with 6 or more ACEs died on average 20 years earlier compared to their counterparts who had not experienced ACEs. An interesting piece of biomedical research that I want to address is that even when researchers can control for health risk behaviors like smoking, substance misuse, exercise, and healthy diet, they're only able to attenuate the overall risk for these outcomes by 50%, meaning that if a person never engaged in health risk behaviors, they would still be more likely to develop all of these conditions. So let me use an example from the slide. People with 4 or more ACEs are at a 390% increased risk of developing COPD. Even if a person never smoked, ate a balanced diet, and exercised regularly, they are still about 195% more likely to develop COPD compared to somebody without a history of ACEs. Researchers explain this by describing the effects of stress. So when stress chronically exceeds a person's allostatic load, lasting neurological and physical changes can occur, meaning that stress on the developing brain and body of a child can result in health problems across the lifespan due to the developmental vulnerability of children who have chronically high levels of adrenaline and cortisol in their bodies, and that has an outsized consequence on their growing brains. So another important component of understanding the effect of ACEs is that there's a dose-response relationship between ACE exposure and outcome. So using data from Felitti et al.'s initial study, Anda found that a dose-response relationship indicated that the higher the ACEs score reported by adult participants, there's a corresponding increase in risk for every health outcome, including affective, somatic, substance misuse, memory, sexual, and aggression-related symptoms. Anda's conclusion continued to be supported in recent literature, and it indicates that the more adverse experiences reported in childhood, the more significant the consequences on physical and mental health in both childhood and adulthood. So in both Felitti and Merrick studies, participants reported that about 2/3 of the sample endorsed a history of at least one ACE. What I want to highlight here is that among the people who reported at least one ACE, 87% of those actually endorsed having multiple ACEs. So that means that as stakeholders in children's lives, it's important for us to be attuned to the cumulative relationship between ACE exposure and harmful outcomes, particularly for mental health. So we've spent some time talking about some of the lifelong effects of ACEs, but there's also empirical support that demonstrates that the negative outcomes of trauma can have an impact during childhood. So overall, higher ACE scores are associated with higher rates of mental health concerns, illness, and socialization problems among children. Kirker et al. Found that for each ACE, there's a 32% increase in the likelihood of having a clinical behavior problem and a 21% increase in likelihood of having a medical condition. For children between 36 months and 5 years of age, for every additional ACE, there's a 77% increase in the likelihood of lower social skills. So in a longitudinal study, Zhang and Mirsky found that ACEs scores at age 5 significantly related to anxious and depressed problems as well as aggressive problems by age 9. In studying healthcare records, Coble et al. Found that children with ACEs are more likely to be diagnosed with ADHD, depression, mood disorders, developmental delays, and other behavioral problems, and that children with ACEs are more likely to be prescribed stimulants and antipsychotic medications. In addition to the physical and psychological concerns we've discussed, children who experience ACEs are more likely to have learning and school-related problems. So a significant finding by Nadine Burke-Harris, who is the author of The Deepest Well and a prolific researcher in this content area, is that children who experienced 4 or more ACEs were 51% more likely to experience learning and behavior problems compared to their peers who did not have a history of ACEs. So in studying suspensions and expulsions of preschoolers, Zhang et al. Found that the likelihood of preschoolers being suspended increased by 80% for every ACE. Blodgett and Lanigan reported that among elementary age children, an increased ACE score was correlated with a lack of attendance, academic failure, and behavioral problems. So there's substantial evidence to support the conclusion that children who experience ACEs are more likely to demonstrate poor outcomes across medical, home, and school settings. So here's a more visual representation of the data that I shared about ACEs outcomes among children. My hope in showing you this is that you can more concisely see these variables here that are commonly connected with diagnoses that are assigned to children who have a history of ACEs. The symptoms that are associated with trauma are also complex and they're very interrelated. And so it can be kind of difficult for us to capture the diagnostic qualities of children who have ACEs exposure, and there are a couple of different reasons for that. So there's a really wide spectrum of mental health conditions that are listed here. A concern that I have is that many researchers and practitioners conceptualize treatments and diagnosis based on discrete presenting concerns. For example, people will develop a protocol for depression, or one for anxiety, or one for aggressive behaviors. What I hope to communicate is that trauma manifests in all people, but especially children, on a wide spectrum. And given the impact of trauma on child development, kids with trauma histories may have multiple presenting concerns, each meriting a response. Researchers have suggested that the creation of novel interventions for trauma exposure or for symptoms can actually limit the scale and the transportability of child mental health services, and that separate protocols to address individual symptoms can be costly and can actually fail to adequately address the underlying contributors to distress. So it's not practical or cost effective to go down a list of diagnoses and treat them one by one. And I would argue that that's not necessarily responsive to the etiology of the presenting concerns of children with trauma histories anyway. So there are a couple of concerns for us to bear in mind when we think about mental health diagnosis and treatment among children. So researchers have suggested that efficacy research about childhood mental health treatments may not actually account for the developmental needs of young children. Public health advocates in the World Health Organization suggested that children have needs that are different from adults and thus experience and engage with the world differently. Yet treatments are often conceptualized first for adult populations and then applied to children as downward extensions of those treatments. Previous mental health outcome research may actually underrepresent children younger than 10 years old, and young children in study samples actually appear to demonstrate weaker responses to treatment effects compared to their adolescent or older counterparts. Overall, treatment efficacy studies of children's mental health have been criticized for a number of different reasons, which include a lack of standardized assessment to measure symptoms across cultures and ages, small sample sizes, a lack of participant inclusion criteria, a lack of fidelity monitoring, poorly defined treatment protocol, a lack of experience of clinicians or a missing description of the clinicians who are involved in treatments, and a lack of ethnocultural treatment considerations. So mental health among children is frequently conceptualized in the extent to which kids meet the expectations of adults, and that's problematic. The most common reason that children are referred for mental health care is due to aggressive behavior, and the second most common reason is learning problems. 76% of children with a diagnosed mental health condition are diagnosed with an externalizing disorder. This information is important to me because I'm worried about the expectations that we have of children's behavior. And I'm worried that kids whose mental health doesn't present as externalized may be missed, that kids who are more compliant or withdrawn are being overlooked because of the biases we might have about children as adults. The total incidence of mental health concerns among children may be underestimated and underreported for those reasons. And the underrepresentation of the prevalence of mental health can be attributed to biases about children's capacities to experience mental health problems like depression, and specifically a lack of measures that are normed for young children or children of minoritized identities. Historically, researchers have suggested that mental health symptoms may be masked by aggressive or anxious behaviors, while contemporary researchers have suggested that parents, caregivers, teachers, and other stakeholders often mistake symptoms for alternative problems, such as conduct or oppositional defiant disorders, and then miss the underlying etiology of trauma or other concerns because they're masked by comorbidity and behavior problems. So observed developmental differences in the onset of mental health disorders across the lifespan have helped practitioners differentiate that there are physiological, cognitive, affective, social, and behavioral sequelae of symptomology between children, adults, and adolescents. According to Mental Health America, 64% of children with a mood disorder will not have access to mental health services. And for a country that spends $247 billion on mental health care for youth, I think that we can do better. And ultimately, I think it's important for us to consider the way that we think about diagnosis and treatment among children, particularly when it comes to trauma. So an important distinction for us to make in this discussion is to make the differentiation between traumatic exposure and the development of trauma symptoms. Exposure to ACEs does not necessarily indicate that a child has experienced events as traumatic or that they have demonstrated trauma symptoms, but the research is clear that adverse childhood experiences are more likely to be experienced as traumatic. Researchers have described that intentional acts of harm that threaten children or their primary support systems are experienced as interpersonal or complex trauma, and they have described pervasive adversity as synonymous with complex trauma. So complex trauma is defined as child maltreatment, domestic violence, and other forms of early interpersonal trauma that may disrupt primary attachments with caregivers, which increases the risk for developing a constellation of difficulties. And it often results in the loss of a child's core capacity for self-regulation and may impact domains of attachment, biology, affect regulation, dissociation, behavior regulation, cognition, and self-concept. Children are particularly vulnerable to frequent and broad exposure to stressful events. Exposure to adverse experiences may be harmful to typical development by reprogramming the body's stress response systems and neurodevelopmental processes that eventually lead to behavioral, psychological, and health problems. Using trauma models, researchers have linked ACEs to the body's response to stressful events, whereby a child's allostatic load, their cumulative response to a threat, activates the body's stress response system for a prolonged period of time, resulting in damaging changes to endocrine, immunological, and several other biological functions. So given this information, I want to go back to the idea of diagnosis for children who have a history of complex trauma and are demonstrating socio-emotional, physical, and academic problems. Some stakeholders, including Bessel van der Kolk, for example, have suggested that even PTSD may not fully incorporate the developmental effects of complex trauma among children. So on this slide are criteria for a proposed diagnosis, developmental trauma disorder. The central argument here is that the diagnostic constructs that are described in the DSM were originally formed from fixed or more static psychopathology states in adulthood, and that they were actually conceptualized through the lens of epidemiology, not etiology. So previously, DSM constructs were referred to as research diagnostic criteria. So DSM criteria may not capture the developmental, progressive, strengths-based, and resilience contexts that are characteristic of children. Stakeholders argue that downward extensions of adult mental health conceptualization are not developmentally sensitive, and that diagnosis and treatment in children should incorporate developmental psychopathology, attachment theory, concepts of neuroplasticity, and resiliency factors. The proposed criteria for developmental trauma disorder are intended to capture the spectrum of dysregulation in children that are exposed to adversity in their environments. So this is a model created by Felitti as part of the original ACEs study. The researchers theorized this pathway from exposure to adversity, here this bottom layer of the pyramid, the subsequent development of mental health problems during childhood, then the adoption of health risk behaviors, the onset of disease, and ultimately early death. For me, this model suggests an important role of caring adults in children's lives. First and foremost, we can create systems that minimize adversity for children. A number of major issues contribute to exposure to adversity: discrimination and oppression, access to healthcare and education, climate change, equitable employment and fair wages, and neighborhood and built environment characteristics are just a few. So through engagement with our communities, we can contribute to the construction of community supports that facilitate equity. And as helping professionals and on a more individualized and direct service path, we can become attuned to that second layer of the pyramid here, the development of social, emotional, and cognitive impairment as predispositions to the development of risk behaviors and chronic mental and physical health conditions. We don't yet fully know the potential impact of mental health intervention during childhood. We would need a lot of longitudinal data for that. But I would hypothesize that the development of coping strategies, internal and external, may support children's social, emotional, and cognitive functioning and change their trajectory imposed by adversity. So here's where the conversation becomes a little bit more hopeful. In a study conducted through the Center for Play Therapy, cumulative childhood adversity positively predicted child trauma-related distress. But the researchers also found that the link between exposure to cumulative adversity and child trauma-related distress varied as a function of protective factors. So there's a positive association between adversity and child trauma-related distress for children who had low levels of protective factors, but not for those who had high levels of protective factors. So similar findings were observed when data was actually stratified by types of ACEs exposure, so maltreatment or household dysfunction or community level stressors. Another research team, Blodgett and Lanigan, proposed that the development of trauma symptoms does not have to be an inevitable conclusion for children who have experienced ACEs, because protective factors, which include safe and nurturing relationships, as well as family and community supports, can actually mitigate risk. So while the plasticity of the brain during early childhood increases children's vulnerability to adversity, the same plasticity actually provides an opportunity for effective treatment and relationship support. So we've discussed trauma in terms of adverse childhood experiences, but some researchers have actually gone as far to describe protective childhood experiences. Protective factors can include using individual coping strategies, peer support, individual coping skills, caregiver physical caregiving, caregiver psychological caregiving, and educational involvement. So trauma is multidimensional, and childhood adversity may best be understood in relationship to the protective factors embedded within a person's lived experiences. So for example, resilience might be an effective way to describe the complex and cumulative relationship between stressors and strengths. researchers define resilience as the development of competent, positive coping based upon individual and family qualities, lived experiences, sociocultural influences, and access to systemic resources. There are many ways that these protective factors or resilience can be identified by counselors, teachers, and the children that we work with if we're attuned to listen for them. Some can include feeling loved by your caregivers, identifying others who help your caregivers, like neighbors or extended family members, feeling that people like to play with you and that you like to play with them too, that there were people in your life who made you feel better when you were sad or worried, that your neighbors or your parents' friends seem to like you, that teachers, coaches, youth pastors, and babysitters seem to like you, that someone in your family cared about how you did in school, that your family and the people around you talked about making your lives better and had hope for the future, and that there were people you trusted when you needed someone to talk to, and that people noticed that you could handle things and that you were capable. As I give this presentation, I feel aware of the protective factors in my own world. My mom is watching with you all tonight, and she's the most resilient person I know. Some of you may know too that I'm the coordinator of the Military and Veterans Counseling Program, and that I'm a military spouse. I want to acknowledge my partner, Russ, who is just as much a counseling spouse as I am a military spouse. I have supportive colleagues who not only care about children, but care about me, and they encouraged me to share my knowledge and my experience with you all tonight. It's been a difficult year for a lot of different reasons, and I'm really grateful to the people in my life who remind me of my humanity and who provide me with a sense of belonging and support my personal and professional growth. I think that it can be easy to frame advocacy and calls to action in terms of adversity or in terms of the deficits in our lives. But the research bears out that it's the relationship between stressors and protective factors that most meaningfully predicts our wellness. So we're going to shift a little bit and talk about neurobiology. I referenced a few components of neurobiology, but I think it might be helpful to talk a little bit more deeply about it. So the brain is developed from the back to the front so that the fastest and strongest neural networks needed for survival are developed first. So for those of you who are familiar with Dan Siegel, he operationalizes a hand-brain model. So I'm going to share this one with you. So your forearm represents the spinal cord. Your wrist represents the brain stem. Your palm is your limbic system, where your emotional processes and fight, flight, freeze, and faint responses are derived. The first knuckle of your thumb is your amygdala. The remainder of your thumb represents the hippocampus, and your fingers represent your cerebral cortex, and where your knuckles close over your thumb is your prefrontal cortex. So as we experience ourselves and our environment, neurons form synaptic connections and carry energy and information to other neurons and all aspects of experience and form what's called a neural net, and then it encodes a representation of that event. So memory occurs when a neural net is activated by your current experience. A neural net is potentially altered by the energy and the information of the present moment. So all of our experiences contribute to the development of neural nets. And that's how we relate to ourselves in the world. So let's operationalize those concepts just a little bit. Sensory information converges on the thalamus, this part of the brain right here. And the first neural pathway passes information onto the amygdala to interpret the emotional significance of that event. If the amygdala detects that there's a threat, it sends a message to the hypothalamus to secrete stress hormones to defend against the threat. And then a second neural pathway sends that information to the prefrontal cortex to refine and interpret that information. Trauma increases the potential for misinterpretation of the threat, which can lead to an overly intense reaction of the amygdala, which might overtake the prefrontal cortex. So here's another way of looking at it. The lasting effects of trauma on the brain are demonstrated with long-term dysregulation of norepinephrine and cortisol systems. When exposed to stress over time and through the process of neuroplasticity, we actually become more sensitive and attuned to the threats in our environment to enhance our response to those potential threats, right? It's adaptive. So structures in our brain can actually increase in size to accommodate processes that support our growth and our survival. There are a few things that I want to highlight here. Under the words healthy brain, the scientists who created this image explain that this PET scan of a brain of a normal child shows regions of high in red and low, black and blue activity, with a balanced distribution of activity that extends through the temporal lobes. And that's where in our brains we derive our capacity for impulse control, problem solving, focus, and language, which ultimately supports our regulatory processes. On the other side of the screen, you can see that the child who has experienced abuse does not have much activity or red in the temporal lobes. I want to dispute the word normal and suggest that for a child who experiences frequent and consistent disruptions to their sense of safety, their sense of self, their corresponding neurological and physical challenges are responsive and adaptive to that child's environment. I think words like normal pathologize appropriate developmental responses to traumatic exposure, and they actually distort our capacity for empathic understanding. And they impede our ability to promote resilience among children who have faced adversity. Wiring and rewiring in the brain supports children's integration of experiences, and it influences the structural components of the brain, meaning that relational experiences and social interactions drive brain development. Children's experiences, whether they are optimal or challenging, create neural pathways for the brain's 100 billion neurons. So experiences influence the structure of the brain and the subsequent mental processes that children possess. Slower and regressed development is a developmentally appropriate response to trauma. And I think it's important to conceptualize events as abnormal and not children's reactions to such events. So now we're going to talk about resonance circuitry. So at birth, neurons in the brain are largely disconnected, but we are genetically primed to make synaptic connections through relational experiences. As humans, we're socially embedded, and this is evidenced in our neurobiology. Resonance circuitry, which is enabled by mirror neurons, is a process by which our neurons fire when we even just observe or perform a particular action. So resonance circuitry explains the way that our brains can be linked together, allowing for emotional attunement and empathy. And those are processes that require more visceral, emotional, and cognitive information. So they're very integrative. These are critical contacts for counselors, teachers, and caregivers to maximize in their relationships with children, particularly as opportunities to enhance those protective factors that we talked about. So here's a video that provides a more descriptive explanation of mirror neurons.
Let me take you back to the early 1990s. Sleepy little laboratory in Parma, Italy, and scientists had a MRI brain scanning machine on a macaque monkey as the macaque monkey was trying to open up a nut. They wanted to see how the neurons would light up. So the monkey's trying to open up the nut, the neurons light up, and just by serendipity, and this is how science sometimes happens, a human being walked into the laboratory. I don't know if it was by mistake, and he was hungry. He saw the nuts and opened up one of the nuts and tried to crack it open. The macaque monkey was totally shocked because who was this invader in his laboratory? And he didn't move. He just gazed at this human trying to open up the nut, just like he had done a few seconds earlier. And then the scientist looked on the MRI brain scanner. The same exact neurons were lighting up when he observed the human being opening the nut as when the monkey opened the nut. And the scientists had not a clue as to what this was. They thought the MRI machine had broken. They then began to put MRI brain scanning machines on other primates, especially chimpanzees with our big neocortex. Then they went to humans. And what they found over and over again is something called mirror neurons. And that is that we are apparently soft-wired, some of the primates, all humans. We suspect elephants. We're not sure about dolphins and dogs. We've just begun. But all humans are soft-wired with mirror neurons so that if I'm observing you, your anger, your frustration, your sense of rejection, your joy, whatever it is, and I can feel what you're doing, the same neurons will light up in me as if I'm having that experience myself. Now, this isn't all that unusual. We know if a spider goes up someone's arm and I'm observing it going up your arm, I'm going to get a creepy feeling. We take this for granted, but we are actually soft-wired to actually experience another's plight as if we are experiencing ourselves. But mirror neurons are just the beginning of a whole range of research going on in neuropsychology and brain research and in child development that suggests that we are actually soft-wired not for aggression and violence and self-interest and utilitarianism, that we are actually soft-wired for sociability, attachment, as John Bowlby might have said, affection, companionship, and that the first drive is the drive to actually belong. It's an empathic drive.
So I really appreciate that video because it highlights the social embeddedness of people and the very natural and biological ways that connection is supported. So we're going to shift a little bit and talk about empathy and how that factors into resonant circuitry. But I couldn't do that without first sharing my favorite quote by Carl Rogers. When the other person is hurting, confused, troubled, anxious, alienated, terrified, or when they are doubtful of self-worth, uncertain as to identity, then understanding is called for. The gentle and sensitive companionship of an empathic stance provides illumination and healing. In such situations, deep understanding is, I believe, the most precious gift one can give another. The subtle but incredibly powerful impact of empathy can be communicated in our relationships with children, regardless of our personal or professional role or our theoretical orientation. So it's something that we can engage in holistically, and it's something that can help support the protective factors that we talked about. So here's another video that depicts the way that empathy plays out in our neurobiological development.
There's a tiny circuit that can save the world. It's in your brain. It makes empathy. Now, we desperately need that circuit these days since we're facing enormous challenges that require all of us to work together to solve them, and empathy is what allows us to get along with one another. But just now, when we need it the most, we're actually losing empathy. There's an empathy gap, and people are noticing.
Empathy.
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 The best companies can, quickly empathize.
That's the essence of empathy.
We've always had that segment of society that lacks empathy.
Sarah Conrath at Indiana University has done a study showing that American college students have been getting less and less empathetic, with the sharpest drops coming since the year 2000. So how do we fix this? The answer comes from the very latest in neuroscience, and I'll get to that in a bit. But first, what exactly is empathy? Empathy is when you imagine what it might feel like to be in someone else's shoes. This can be really hard to do. Like, for example, right now, I'm in my wife's shoes. And it feels really awful. Gotta switch to sensible pumps. We humans have been empathizing since, before we even had shoes. Compared to other animals, we weren't so good at doing things like leaping or having claws. We survived because we had this one superpower. We could imagine what another person might be feeling. This allowed us to work really well in groups, so we could do stuff like farming and hunting and such.
Humans are really social creatures, and to live and survive, we believe we need empathy. So it's not enough to have just physical survival on your own. For a human, we have to live in groups, and we have to cooperate and get along. And so it's important to know when someone feels sad, for example, or is in pain, and empathy helps us to share that person's feelings and to help them. We also think it's really important to share other humans' positive emotions, and positive emotions play a really important role in social life. They are at the foundation of human relationships. They help us to stay connected to others for years and decades of our lives. And those kinds of relationships are crucial to survival.
Not that we're the only animals who have empathy. So do some of the other big-brained creatures, like the great apes, along with elephants and whales and dolphins. Those other animals have one kind of empathy, emotional empathy. They instinctively put themselves in another dolphin's flippers. We humans have emotional empathy too, but we also have a second kind of empathy, a kind that lets us use our experiences as well as our instincts so we can better imagine things from someone else's perspective. Empathy can sound like kind of a mushy concept, but no.
Empathy isn't mushy, it is hard science.
Neuroscientists like Dr. Bruce Miller first discovered the empathy circuit when they were working with patients who had a particular kind of dementia called frontotemporal dementia, or FTD. Many of them lose their empathy.
Imagine an illness when the first manifestation of this is that you don't care about your children, your partner, your loved ones. When someone suffers an illness, you don't care. This breaks down everything about our humanness, our human connection. So what connects us to people is suddenly disappearing.
When brain scientists like Bruce Miller and his colleague Bill Seeley were studying people with FTD, they noticed that certain parts of their brains had shut down. They looked at where their empathy wasn't, and that showed them where empathy was supposed to be. And that's when they discovered the empathy circuit.
Regions in this circuit help us to detect other people's feelings and then produce an emotion in response to those people's emotions. So for example, there's parts of the temporal pole and the amygdala that are really important in helping us to understand other people's experiences and emotions. And these systems project to the anterior cingulate cortex that then generates this emotional reaction throughout the body, through the autonomic nervous system and the face. And that system produces this emotional reaction. Really important structure in the system is the insula. And the insula is a part of the brain that helps us to represent our internal states. So it's not enough to just have the brain produce the emotional reaction, but then our brain has to represent how the body has responded and monitor those internal cues. And once we access those internal feelings, we can better gauge our internal states and then act empathically.
This is a circuit we never realized existed. This is a circuit that has grown as the human species has grown.
So how exactly does empathy work? Let's say I'm hanging out with you. You know what? We can use a visual aid here. Could you just tilt your chin just, yeah, like, no more. And let's say I start to get upset. Now you start to empathize. You pick up on my emotion and you start reflecting it. And not just in your brain. The more you empathize, the more your whole body can get in sync with mine. Facial expression, heartbeat, breathing, posture. Now you go further. You try to comfort me because you're obviously such a cool person, and it works. But what if you don't empathize with me? Wow, and I thought you and I were buds? And what if it's not just you and me? What if it's a whole lot of us? Well, then eventually our empathy circuits will actually start to get weaker, and we might become less empathetic to the next person we encounter. We retreat to our own little groups, our family and friends, the people we consider us as opposed to them. And everyone outside of that group becomes the other. Society breaks down. The collective empathy circuit is broken. And we don't know why, but we start to feel off. It's because we're not connecting to our fellow humans. We want to reach out, to empathize. It's in our nature. But our empathy circuits are weak. So we tend to connect less and less, especially with people who are outside of our little group, till we reach a point where, because we're so divided, we have all these terrible problems, and also because we're so divided, we can't work together to solve them. Okay, now that I've completely bummed you out, here's the good news. We can fix this. We can actually strengthen our empathy circuits. If you're old like me, you probably remember 8-minute abs.
And just crunch right up. My feet are on the ground.
Well, there's a simple exercise you can do every day to strengthen your empathy circuit. You could call it 8-minute EMPS. You know, EMPS for empathy. I'll work on it. The exercise begins when you realize you're feeling a negative emotion towards someone. Like, let's say you're online at the supermarket and I cut you off. This makes you angry, and you realize that's what you're feeling. So now here's what you can do. First, take a deep breath, or two. Next, use your imagination to try to figure out why I was so rude to you. Maybe I just found out that my mom needs surgery. Maybe someone was just rude to me. You don't have to guess the right answer. I mean, usually you won't be able to. But just trying to imagine how I'm feeling and why will strengthen your empathy circuit. And when I pick up on your empathic vibes, then I might start building up my own empathy circuit. And then these waves of empathy can start to spread.
In a culture or in a society, empathy does emanate out from individuals. Those kinds of feeling states could rapidly be transmitted across people, communities, states, countries.
We don't have to love everyone. I mean, we can't. But we can almost always empathize with them. It starts with just a small leap of imagination between you and me. And then it spreads in more little leaps and more till it all adds up to one enormous leap, so powerful that it can solve seemingly insurmountable problems.
It seems like it's not just like a cool thing or maybe a fun thing to learn about how your brain generates empathy and what the empathy circuit is, but it actually is an important thing. It's like an important thing as a citizen or as a parent.
It's the most important thing.
Wait, say that again?
It's the most important thing, to be empathic.
When you see people with frontotemporal dementia, they are alone. They are isolated. And you can imagine a country losing this circuit. They will become isolated. They will become alone. And conversely, you can imagine what happens to a person who cares about others, who connects to other people. Their world gets bigger, richer.
So brain science can help us to save the world. It can help us to save humanity.
I think we must unite. There's so many things that threaten humanity that will make things worse if we aren't united, if we don't work together.
We can do this. We have to do it. We want to do it. You feel me?
I think you do.
So I appreciate you all hanging in there with me for that long video. I guess I'm making the assumption that you did, but as I was trying to decide which clips to use, they all felt so relevant to so many of the contexts that are happening in the world right now. That because of social distancing for the past year, our ability to be with people is different. As I teach classes to counselors, I notice that it is different. Even when we're face-to-face synchronously on our screens, we aren't exchanging the same kind of energy and the same kind of feedback that we would if we were all in the same room. And I also appreciate the way that they talked about empathy as something that can be entirely nonverbal. It can be something that, we're wrong about. We don't always have to know the answer about what someone else is experiencing, but by engaging in that empathy circuit or in that resonance circuit, we are communicating with the people that we're socially embedded and in relationship with, and that has meaning and a positive impact in and of itself. So I'm going to take that 10 minutes of really well done high video production quality and try to summarize it again for you here in this slide. So this is my visual for how empathy can look. So cognitive theory of mind is the ability to attribute mental states to ourselves and others. And it's a foundational component of our social interactions. So cognitive theory of mind utilizes the medial prefrontal cortex, the superior terminal sulcus, and the temporal lobe. And it allows us to recognize about another person. I know she's thinking about her family. Then cognitive empathy stems from affective theory of mind, and it utilizes the ventromedial prefrontal cortex and allows us to recognize something a little bit deeper. I know that she has been feeling lonely lately. And then finally, affective empathy takes us a little bit deeper, and it utilizes the insula, the amygdala, and the anterior cingulate cortex, and it allows us to feel something. So I feel her pain. This empathy facilitates an exchange between people that supports synaptic connections to build neural nets for safety, understanding, and acceptance in our relationships. So here we're going to operationalize empathy in our skills as helpers, whether we identify as parents, school counselors, teachers, psychologists, or clinical mental health counselors. So let's say a child is playing with a doll and says to you, "She's hungry, it's time for lunch." In a reflection of content, you might say, "Oh, she needs to eat." The child brings the bottle to the baby, but then wrinkles their brow and looks from the baby around the room and says, "She doesn't want this." And so you reflect, "You're worried." And then the child hands you a spoon, and to facilitate the relational process unfolding between you, you say, "You want me to help." And the child supports the baby over her shoulder and starts rocking and hushing the baby. And to reflect deeper meaning, you say, "You're taking care of her." These types of verbal responses offer progressively deeper statements of empathic understanding for the child that we are in a relationship with, allowing them to experience our understanding, our acceptance of them, and the safety of our relationship, which creates opportunities for them to explore relationship, to explore their own regulation and their own problem-solving skills. While these verbal responses are really important, their sincerity and the capacity for their effectiveness is entirely underpinned by actually nonverbal skills. So let's look at some of those. There are several indicators that we're holistically connected with our clients. Physical attunement is a kinesthetic and emotional sensing between people that is characterized by eye contact, matching facial expressions, and motor movement that provides reciprocal affect or a resonating response, which communicates our understanding and acceptance of the other person. Brain-to-brain synchrony is a neural marker of moment-to-moment interactions between two people on a neuronal level. So in a way that the behavior of each person is actually coupled to the brain of the other. Examples of this can be observed in matching affect, joint engagement, where two people are focused on a common object, contingent responding, where you might follow a child's lead in conversation with active listening, and reciprocation with relevant responses, and physiological attunement, such as heart rate or breath. We can co-regulate with children by ensuring that the words that we're using are emphasized by the tone of our voice, the rhythm of our speech, the rate of our speech, and our physical openness to the child, so our body positioning. I think that in a field where we have heightened awareness of injustice, abuse, and hardship, we really want to respond to mental health need with speed and force in a way that matches the urgency of the stories that we hear and the pain that we witness. I just want to acknowledge what an incredible impact these seemingly small but meaningful skills and ways of being can have to promote relationship connection and growth. I think the reason that so many of you are here tonight is because you want to move mountains for people who are in pain. And what I hope you walk away with is a sense that we can do that first and foremost with empathy and attunement, and amplify every other thing we do. So to prevent dysregulation, so we're going to transition a little bit here and talk about what are some things that you can do in your environment to prevent dysregulation, and then when dysregulation is happening, what are some things that you can do to intervene? So there are several verbal and nonverbal behaviors that we can implement to create environments that are really characterized by safety, consistency, self-responsibility, and empowerment. So when kids have a sense of what they can expect from us and what we can expect from them, they have the opportunity to develop self-control and engage in more mutually agreeable behaviors. What often happens is that kids who live very much in the present moment have their own agendas disrupted, or they can even feel rejection or failure when they don't meet our expectations. So we can identify times that kids might struggle, and when we observe patterns, we can plan ahead for those. So transitions seem to be a stress point that is noted by parents, teachers, and counselors. So for example, getting out the door for school at the beginning of the day, transitioning between activities during the school day, or coming into or leaving the therapy space of the playroom. When we as adults are attuned to these moments of greater tension for kids, it can help us to have a game plan. So we can give warnings like, we have 5 more minutes of time together. We can get support from other adults. Maybe a little one is struggling to end their session with you as a counselor, and you have another little one waiting. If that becomes a pattern, you might choose to end sessions a couple of minutes earlier to give that child a longer period of time to regulate and leave the playroom. So you can support them through co-regulation and attunement, but you can give them the opportunity to utilize their internal resources and their own self-control and their own self-limiting by giving them a longer runway. So sometimes I have parents who really want to intervene when their child is struggling in therapy. And sometimes that's the most appropriate option, and it becomes part of the planning that we do. But what's really important for me is to be aware that for parents, intervening in their children's dysregulation in public is often full of tension, frustration, and possibly embarrassment. So it's important for me to talk with them beforehand and establish a really strong collaborative relationship with them so that we can work together. In a nutshell, come up with a game plan that allows space for patience and time for kids to practice regulation. I think that's one of the most special things we can do in counseling. We don't always have time and patience and resources in other settings, but in counseling we do. And so allowing our structure to accommodate some of the struggles that kids have is like golden time that they often don't have in any other part of their life. And so I think it's really important for us to try to be able to provide that. It's helpful for us to show kids our understanding and our acceptance of them, even when we need to set limits on their behaviors. So it helps them build those neural pathways for self-regulation when we engage with them in co-regulation. Acknowledging kids' feelings and ensuring that they feel understood can help them move forward. We can do that by noticing and naming the emotions that children feel in the moment and doing that as a holistic practice all the time so that they can adopt that language and more easily name their own internal experience. So as an adult, it's hard for me to move forward if I don't feel understood. Children are just the same. For children who are still developing their sense of self and their problem-solving abilities, we can support them by leading with understanding of where they're coming from and letting them know that we understand. We can create opportunities to give kids choices as a part of all of our interactions with them. Choices are empowering and they give kids the chance to feel a developmentally appropriate level of power and control. Choices also give adults the opportunity to create terms that they are willing to live with and provide alternatives to kids who may not yet have the developmental capacity to see multiple solutions at a time the way that we can as adults. We can implicitly communicate our trust and our care for children by giving them ongoing opportunities to express their preferences, their personality, and their power. Encouragement rather than praise is an important component of esteem building for children. Encouragement facilitates an internal locus of control for kids rather than dependence and an external locus of control or evaluation. So when kids say, "Do you like my painting?" we can say things like, "You're so proud of that. You really want me to see." It's important that we communicate mutual respect for children. Sometimes we can do this goofy over-under thing as adults, where we either consider them to be mini adults who think and experience the world the same way that we do, or we can totally lack trust in them and undermine their opportunities to scale their learning and engagement as they grow. So for example, have you spent very much time with 4-year-olds? Because that has been very much part of my world for the last 5 years. If so, do you have a sense of frequently warning them to be careful? Because I do. 4s have a lot of energy as a result of actually a very rapid metabolism and a heart rate that pumps proportionally more oxygen into their blood. So this is a unique experience for 4-year-olds. These processes are heightened for them. 4s also grow about 3 to 4 inches in that year. And so they can often be observed running into things, eliciting caregivers or the adults in their lives to flinch and give a lot of warnings for them to look where they're going. What's interesting is that clumsiness is not because they're not being careful. It's actually because they're visually focused on objects in the distance rather than those in close proximity. So a side effect of the important ability to develop the ability to focus on objects far away. So it's actually a really essential developmental process that's happening. It's not carelessness on their part, yet that seems to be the redirection that we frequently give them. So when we have information about development and trauma, we can be more understanding of what kids are struggling with and how to support them. So rather than approaching them with frustration, we can give a more attuned redirection and demonstrate a mutual respect for the things that they want, need, and feel. By offering choices and modeling the process of asking for help, we can also create opportunities for kids to find new pro-social ways to get their needs met. So prior to the more advanced development of the prefrontal cortex, kids learn best by doing through physical physical activity like drama, dance, or play. Something that in the play therapy world we say a lot is from the hand to the head. So experience and relationships are children's best teachers, and we can support kids by showing them more so than actually by telling them. We can also create kid-friendly spaces that have tactile and sensory coping items and are part of an overall soothing environment. So I really recommend for people who are working with children in a clinical setting to have spaces that are not overly cluttered or too bright. I think it's tempting to think of kids' spaces as bold and colorful in order to be welcoming to them. But as a counselor, knowing that I work with children who have trauma histories, I try to create a more neutral space and welcome them in other ways, like by having kid-sized furniture or hanging pictures at kids' eye level rather than at adult eye level. In classrooms or in counseling, I also recommend that we create opportunities for kids to get physical movement. Whether that's something that we can facilitate based on the setup of our counseling rooms or classrooms, or it's just in the structure of our time together. So I worked at a private practice that had a backyard in it, and it was really powerful to give kids the chance to work around and choose their physical proximity to me while they were processing. And if you're interested in research about the therapeutic effect of green spaces as part of play therapy, I encourage you to look at research by Jacqueline Swank or Kim Walker. Those are two really exciting areas of development that are happening in the play world right now. So intervention practices. Children who have experienced complex trauma often become dysregulated in the course of their interpersonal interactions and behaviors. So when children are dysregulated, soothing techniques can be more effective than teaching practices. So the idea that you don't want to teach someone how to swim when they feel like they're drowning. I think it's really natural for us as adults to try to explain ourselves or give information, but often these things actually are more about our needs as adults than they are about kids' needs right in that moment. So it's meaningful to address the immediate stressor and then try to teach or explain things later when kids are a little bit more regulated and better receptive to what you're trying to communicate to them. It's important for us to be grounded in order to facilitate co-regulation. So that means that we need to do our own work about our expectations of children, the biases that we might have, our values, and even our own tender spots, so that we can notice when we're dysregulated and then take the steps that are needed to regulate so that we can support little ones. And we need to approach them as gently as we can so as not to contribute to their dysregulation by startling them or towering over them. I worked in a Title I preschool for 3 years providing therapeutic services. And there was one little guy that I worked with, he was like kind of known as a runner. And sometimes when he would start to take off, the other adults in the room would immediately jump up and start to take off after them, which I understand. But really the dynamic that happened there is that he tended to run faster and harder than before. And he became then dysregulated, and then he became afraid of getting caught. And so it was this really difficult like feedback loop between all of them. And so, we have to be really thoughtful about, how from our size and our strength as adults, we're impacting children who are already on the edge of dysregulation, and ways that we, even when we're doing what we need to do to keep them safe, we can sometimes contribute to their dysregulation. And so we need to be mindful of that for ourselves. When kids are dysregulated, you might have heard people describe that as flipping your lid. So going back to that hand-brain model, what that means is that their functioning is dominated by their limbic system and the midbrain. So it's mostly feelings and very little logic. So here's flipping the lid. So to co-regulate with kids, we model our own regulation process and we provide physical and emotional safety and then sit with them as they regulate. So what frequently happens is that a child flips their lid and then, if there's like a safety concern or they scream or whatever is going on, whatever alerts us to the fact that they're dysregulated, we tend to temporarily get dysregulated ourselves. And so our mirror neurons are all dysregulated, and our brain-to-brain feedback is full of chaos in the moment. But then as we regulate ourselves and we put our lid tightly back on, kids actually have the opportunity to regulate themselves when we model that process for them. And so when they're dysregulated, it can be really difficult for them to integrate information and to sequence events and solve problems. So it's really helpful for us to limit our words, give really small steps, and do little pieces at a time while they're working on bringing their cortex back into the locked and loaded position. It's also important for us to reflect their feelings. Like, you're so angry, that didn't feel fair. You wish it were different. You wish you could keep playing. Wiring and rewiring in the brain happens extensively to help children actually integrate their experiences. So experiences influence the structure of the development of the brain, meaning that relational experiences and social interactions drive brain development. And that's the importance of having relationally based counseling interventions for children. That's why those relational protective factors are so important. So the biggest neurological pruning that happens in our lifetime happens when we're between 5 and 11 years old. So supporting relational synaptic connections is vitally important to brain growth in children. So after we've supported some regulation in kids, then we can target alternatives to whatever the conflict at hand is. So here's an example of how that might look. First, I reflect, you don't want to stop playing. And then I state the limit. It's time for us to go meet your mom. And finally, I target an alternative. You can choose for us to skip or hop back to the waiting room. In that example, I chose a playful alternative to leaving the room to empathically address the child's distress that the playtime was over. And so it's really important that we have empathic understanding and reflect their feeling, and then give sort of a corresponding alternative to target. The last one that I'll talk about is especially important if you're in a setting where there are lots of kids or people. So if the child that you're with is dysregulated, it can be very helpful to move away from peers or other people for a couple of different reasons. One, the energy from others might be really difficult to overcome. So for instance, in that preschool setting, if the little guy that I was working with was getting dysregulated, he tended to kind of feed off of whatever chaos was happening in the classroom. And then the other thing too is that kids are sensitive. And so others seeing a meltdown might elicit feelings of shame or embarrassment for the child that we're working with. And so if it's possible to get them into their own space, that can be helpful. Okay, so now I'm going to talk a little bit about the research that I've been doing at the Center for Play Therapy. There's some promising evidence. I know we've painted sort of a gloomy picture today, but there are exciting developments in the world of counseling. So play therapy is what I practice with kids, and play therapy is defined as a dynamic interpersonal relationship between a child and a therapist trained in play therapy procedures who provides selected play materials and facilitates the development of a safe relationship for a child to fully express and explore themselves, their feelings, their thoughts, their experiences, and their behaviors through play, which is the child's natural medium of communication for optimal growth and development. So communication with words feels really natural to adults, but by contrast, the natural language of children is play. So words are abstract in their nature, but play allows children to experience concrete, active interaction with their environment, and it allows them to receive negative or to receive felt consequences. So as children explore their worlds in play, they're given the opportunity to feel a sense of control and a sense of security. Young children in particular are drawn to symbols for expression, and they express their internal worlds almost entirely through play, particularly to convey their emotions. Even as children acquire language and get older and their communication expands, they still tend to gravitate towards play components to express themselves. So play really allows children the opportunity to learn and explore novel ways to sort of meet and organize the demands that they experience in their world, and it bridges their language acquisition. Playrooms are important. They offer durability, and they enable the play therapist to remain fully present and accepting of the child's exploration. They enable the child to navigate the space with structural and relational safety and acceptance. Toys and materials in playrooms are very carefully selected, and they are comprised of both real-world objects and then more childlike engaging toys. Toys and materials represent particular categories. So real life toys like dolls or vehicles or costumes, musical instruments, acting out, and aggressive release toys like a bot bag, like a big indestructible punching bag, toy soldiers, guns, swords, shields, toys for creative expression and emotional release like sand, paint, and scissors. All of those items provide kids with tools to support the communication of their inner world in the course of the play therapy. And it's really important that we facilitate the availability of a broad vocabulary for them by providing toys in each of those categories. So something that people are especially concerned about is providing aggressive release toys to kids. But I would frame that concern in a parallel to adult or verbal styles of counseling. So in talk therapy, we would never limit or shut down an adult's expression of anger or intensity by forbidding that they express anger, right? So if you think of play as children's language and toys as their words, we want to ensure that they have the opportunity to really fully express their internal experiences, but we remain fully accepting of their feelings, and then we redirect their behavior as necessary. So in child-centered play therapy, it's a therapy that is developed to be developmentally responsive and culturally responsive, and it is from the person-centered philosophy. So verbal and nonverbal child-centered play therapy responses are characterized by their communication of these be with messages. So this idea of I'm here, I hear you, I understand, and I care. Those sentiments underlie all of the communication that occurs in child-centered play therapy and are operationalized with verbal and nonverbal responses. So some of the verbal responses include tracking behavior, reflecting content, reflecting feeling, facilitating decision-making, facilitating creativity, esteem building and encouragement, facilitating relationship, and limit setting. So I hope you hear the parallels there in the concepts that we talked about in neurobiology and development. I want to bring child-centered play therapy and trauma together here and describe my theory for the way that child-centered play therapy actually addresses trauma symptoms. Symptomology can develop from a broad range of underlying emotions and experiences. So fearfulness, irritability, and hyperarousal are very characteristic of trauma. And many behaviors like withdrawal, avoidance, or aggression can also manifest. So from a child-centered developmental perspective, children's behavior is directly consistent with the child's view of themselves. Their affect, their cognition, and their behavior are considered holistically, and they're not parsed apart as targets of therapeutic intervention. Rather, the child-centered play therapist is actually seeking to understand the child's internal frame of reference without a focus on modifying behaviors or perceived deficits in the child. So total communication from the child is inclusive of the child's underlying emotional experiences, their externalized behaviors, their ways of viewing self, the world, and their relationship. And those allow the play therapist to empathically understand and then more accurately perceive the child's world. So children's holistic engagement with their environment is their mechanism for satiating their needs. And so they're not understood as maladaptive. Instead, from a child-centered perspective, children are seen as moving towards self-enhancement and growth. So here's another visual representation of that therapeutic process. So children develop their self-concept based on their lived experiences and their need for acceptance in their relationships. And mental health symptoms can begin to develop when children experience discrepancies between their self-concept and their experiences. So children's responses to these discrepancies can include a wide range of emotions, behaviors, and meaning making. So theoretically, child-centered play therapy addresses the discrepancy between a child's self-concept and their organismic experiences. So those discrepancies can result in a child feeling incapable of meeting the demands that they perceive in their environment, especially resulting in a lack of feeling safe or unable to trust oneself or one's environment. And that is what causes the resulting clinical mental health symptoms. So from a child-centered perspective, children's poor self-concept is addressed by the mechanisms of safety and relationship that are provided by the play therapist. The non-directive nature of play attunement between the child and the counselor in a calm environment, the therapist's congruent and limit setting provide the child with a feeling of safety. And then the counselor's provision of verbal and nonverbal responses, the counselor's unconditional positive regard, and their empathic understanding establish a relationship of acceptance and caring for the child. And cumulatively, those components provide the child with the freedom to express their experience of trauma and naturally move towards confronting their own perceptions of inadequacy and unsafety, and begin to experience themselves as capable and safe so that they can begin to build coping skills and make more positive integrations to their self-concept. So, it's really difficult that we can't necessarily change the world that children live in, but we can be with them as they find ways to respond more adaptively or more self-protectively to the world that they're a part of. And we're creating an opportunity for them to do that in the context of empathy and caring relationships. Child-centered play therapy is well researched. These 3 meta-analyses represent results from a number of randomized control trials and have included more than 1,400 children in each of those studies. And something that I just want to call your attention to a little bit more specifically is the age of the children who are involved in these studies. So much of the child therapy research that's out there has really included older kids, and with younger kids, we see smaller effects. And actually, we even see a trend of deterioration of mental health symptoms in younger children who are exposed to developmentally inappropriate styles of therapy. And so the fact that play therapy, and specifically child-centered play therapy, is effective with the younger population is really important for us to pay attention to, especially if you're thinking about referrals, even if you don't work with children yourself. So these 2 studies represent randomized control trials that I was a part of, and so I'm really excited to share those results with you. ACE's research about children has been limited. It's only really been within the last few years that we've seen more come out about the effects of ACEs during childhood. So recently I served as the project manager for a large-scale randomized control trial out of the Center for Play Therapy, where we looked at a really broad spectrum of mental health symptoms that impacts children. So we looked at attention deficit and hyperactivity, social and emotional skills, internalizing and externalizing problems, behavior problems, mindfulness, and academic achievement. As part of the large study, we served more than 300 children between the ages of 3 and 10 years old, and we worked individually with more than 100 teachers and parents. So in the first study, we conducted play therapy with 34 children between the ages of 5 and 8 who experienced 2 or more ACEs and demonstrated clinical symptoms of ADHD. We utilized parent and teacher reported symptoms, as well as a double-blind classroom observer to assess symptoms before and after involvement in 16 sessions of play therapy that were conducted bi-weekly for 30 minutes each over a period of 8 weeks. The kids who participated in play therapy improved in the ADHD symptoms at home and at school, and they improved in their on-task, off-task behaviors in the classroom and significantly improved in their academic achievement. What was really heartbreaking is that during that 8 weeks of treatment, the kids who were on the wait list actually deteriorated in their mental health symptomology, meaning that in the absence of mental health intervention, children may actually experience worsening of their mental health symptoms. And so that's really important to me because it means that our role in the community is not just to improve symptoms among the people we serve, but we also serve a really important role in prevention. So this study is really exciting because historically, teachers report the smallest degrees of change among children, but in this study, they reported statistically significant large effects. And so something that works in the classroom is definitely something for us to pay attention to. In the next study, we served 120 children between the ages of 5 and 8 years old with a history of 2 or more ACEs, and we looked at their social, emotional, and behavioral problems. The kids who participated in this study improved in their overall social and emotional competencies and their behavior problems. So I want to talk about how important the social and emotional competencies are and what's included in that variable. So that included empathy, social competence, self-regulation, and self-responsibility. So if you think back to the slides where I talked about resonant circuitry and the neurobiological impact of trauma, these findings are so important. So it's really promising that we can actually improve things like empathy in a period of just 8 weeks of child-centered play therapy. So now we're going to talk about some systemic factors that were interesting and unique about this study. Ultimately, this was the largest play therapy study ever conducted, and we still have a lot of data to analyze and a lot to contribute to the literature. But there are some important components about this study that I want to highlight regarding how we can reduce barriers to care for people who are living in adversity. First, we did 100% of this study in Title I schools. This eliminated the need for caregivers to pay for services or take time off of work where there are caregiving responsibilities for other members of their family in order to get their other kids to therapy. For that reason, we were actually able to avoid attrition from therapy. We went directly to kids in an environment that they were already familiar with. Next, we were able to open access to counseling services for children who might otherwise have been overlooked for mental health need. So we went to in-services with teachers, counselors, and administrators to talk to them about adverse childhood experiences and the array of symptoms that they might see. And we helped by giving them vital information about how to identify children who might benefit from services. So behavioral problems were the biggest source of referral for kids, but by highlighting other symptoms like withdrawal, we were actually able to work with little ones who might never have reached our offices in the community because they never would have been identified as needing support. Another component of being in the schools that's really important is that we were in touch with virtually every significant stakeholder in a child's life: teachers, counselors, caregivers, administrators, and we were able to support all of them through the direct provision of services or just through the process of consultation. And so a primary consideration in designing this study was how to incorporate a culturally responsive program design and provide service delivery to groups who have historically underutilized and experienced disparities impacting their access to culturally responsive and evidence-based treatments. So many of the child participants in this study represented racial, ethnic, and socioeconomically minoritized groups. So children of color and in low-income households may be especially vulnerable to adversity exposure and may be under-recognized and over-stigmatized in terms of their mental health symptoms. Yet, minoritized populations also appear to underutilize mental health services. So in my experience, specifically during this study, boys and boys of color were overrepresented among children who were identified by school personnel or parents as having behavior problems. But boys of color who were experiencing more internalizing symptoms were overlooked and were underrepresented in referrals for mental health care. And by working within school systems, we were actually able to address some of those challenges. Historical and current struggles with depression, with discrimination and racism really have contributed to the etiology of mental health problems, and they contribute to the mistrust of medical and mental health professionals by minoritized persons. So in a Surgeon General report, researchers suggested that by making mental health services more accessible and more visible, we could actually really engage in reducing disparities in access to mental health care, and then try to prevent some of the fragmentation of service delivery that can kind of happen in managed care systems. So we were able to build trust and build continuity with the populations that we were hoping to serve by making sure that we were a presence in their community and by maintaining that presence for a number of years. I was really lucky to be part of that project, but the counselor education faculty members who established those relationships with those schools had in some cases been there for as long as 25 years. And so, it's a long and really meaningful process to ensure that you're engaged with your community and that you can improve mental health engagement by building that kind of trust. And the last thing here for us to talk about is that regardless of the modality of therapy or practice or who you refer to or whatever you're doing, the National Child Traumatic Stress Network proposed this model for providing ACEs-informed interventions to children. So they recommend that you assess for ACEs and that childhood trauma conceptualization should be a standard practice among child clients. But along with assessing for ACEs, counselors should also assess for clients' resilience and their social support, so those protective factors. And it's a passion of mine and the researchers that I worked with on ACE's research that we're also considering the strengths and opportunities for amplifying children's strengths and the mental health interventions that we're providing. So we can enhance resilience by better understanding the support that they get from caring others, trying to enhance their feelings of safety at home and at school by supporting their self-efficacy and their self-esteem, by helping them develop a sense of purpose and meaning, and by amplifying their more effective and their more adaptive coping strategies. And then here are a couple of adjunctive services that you might consider providing referral to that could be great opportunities to strengthen the protective factors in the lives of the children that you are working with. And now I'm open for questions, but I realize that we're close to the end of time, but I hope that I can fit in a few.
Well, we have a lot of questions.